Ladies and gentlemen, it's a great pleasure to have you with us today for this webinar on lessons in rural proofing of health policies, strategies, plans, and programs. My name is Theodora Swift-Kohler, and I am Senior Technical Advisor for Health Equity in the Gender Equity and Human Rights team in WHO headquarters, and I will be the chair for today. Oops. I'm gonna have to quickly download the presentation and re-upload because we're having some screen share problems. Okay. Can everyone see my presentation?
Yes.
Okay. You might want to do on display settings, change view, because we see the one with notes.
Ah, okay.
Display settings, and I think the second option.
Okay, let's see. We did check this before, so let's see if it can come back up now. Okay. Is this working now?
Yes.
All right, perfect. Thank you so much. Okay, so to come back to the kicking off of this webinar, I first wanted to give you a bit of rationale behind the Rural Health Equity webinar series. First, the key point we'd like to start with is that most of the world's poor live in rural areas, and for many health and other important SDG indicators, rural areas are lagging behind. Health inequities in rural areas are really due to two key sources. These are social and environmental determinants of health, as well as weaker health systems in rural areas. So some estimates that were produced in the context of updating the WHO guideline on health workforce development, attraction, recruitment, and retention in rural and remote areas suggested that 2 billion people living in rural and remote areas across the world do not have adequate access to the essential health services they need within their communities. And we also know that through COVID-19, that there's been, that really, while research is limited, COVID-19 has exposed and magnified chronic underinvestment in health systems and health determinants in rural areas. For example, through inadequate numbers of appropriate trained health workers, poor facilities and infrastructure, limited capacity in rural clinics, shortages of key health products like testing kits, PPE, vaccines, weak referral systems, inadequate safe medical transportation, issues related to water and sanitation, housing, quality, all of these have really contributed to COVID-19 being particularly hard-hitting for rural areas. So against this backdrop, we are convening a Rural Health Equity webinar series. This webinar series goes from July all the way through February of next year. We'll be covering a range of topics, including social participation, inclusion, and community engagement approaches for the health of Indigenous populations, rural health workforce, innovations in equity-oriented health service delivery in rural and remote areas, intersectoral action with the agricultural sector, as it's a particularly key employer in rural areas, improving rural health information systems for health equity, and rural women and addressing inequities in health service coverage. Now, this webinar series is being convened under the overarching umbrella of World Health Day 2021, the theme of which is tackling health inequities. It's also being a satellite series to the 18th World Rural Health Conference 2021, convened by WONCA, and Uganda is the host. And also it's fundamentally helping to contribute to the follow-up to the shared UN systems framework for action on leaving no one behind. So a bit about the webinar series partners. First, WHO in a coordinating role, and here we're coming from the Gender Equity and Human Rights team, but we're also working with a range of other teams, including the PHC Special Program, the Health Workforce Program, Health Governance and Finance Program, SCH, so social determinants of health, our colleagues working on health inequality monitoring, as well as a range of other departments and colleagues in our regional country offices. We're partnering with the Wonka Rural Working Party. We're also partnering with different agencies that form part of a rural poverty subgroup of the UN Inequalities Task Team. The subgroup, which is co-led by WHO, FAO, and IFAD, has 15 different UN agencies in it, really focused on tackling rural poverty and rural inequalities. We're also partnering with OECD for this series, as well as academic centers and NGOs working on a range of rural health issues globally. And then for country-specific presentations, of course, we will feature representatives from member state governments, as well as civil society organizations and other partners in those countries. So as part of the introduction and warming up for this webinar that will specifically today focus on rural proofing, I'd like to commence with this presentation on the role of rural proofing health policy, strategies, plans, and programming in building forward better for the rural poor. I'd like to introduce my co-presenters here, Nadaya Belchika, who's lead technical specialist for gender social inclusion in the UN International Fund for Agricultural Development, IFAD, as well as Erdgen Main, who's economist and policy officer, Inclusive Rural Transformation and Gender Equality Division, Food and Agriculture Organization, FAO, of the United Nations. And in this presentation, we'll give you a bit of additional background on rural poverty and let's say, cross-cutting multi-dimensional deprivation issues that are affecting the rural poor and that require a focus on rural proofing. Then in addition, we'll be giving a bit more orientation on the speaker lineup throughout the rest of the series, or throughout the rest of this webinar. Now, with regards to rural proofing, what exactly do we mean? Rural proofing is a term used to describe the systematic application of a rural lens across policies to ensure that they are adequately accounting for the needs, contexts, and opportunities of rural areas. And it's key for leaving no one behind, for reducing inequities in rural areas. This is called for by, leaving no one behind is called for in the 13th WHO General Program of Work and the UNCEB Shared Framework for Action on Leaving No One Behind. I'd like to say that rural proofing is not only about making sure that we address inequities between rural and urban areas, but also it enables a focus on tackling inequities within rural areas. So really applying an intersectoral lens is critical. Now I'd like to hand over to Erdgen from FAO to expand a bit more on rural poverty. Erdgen, please.
Thank you, Theodora. Thank you for the invitation to this important webinar. My name is Erdgen Mann, and I'm a policy officer and economist in FAO. So in my slides, I'll focus mainly on the SDGs 1 and 2. So this first slide, we're talking about the rural poverty, and particularly the monetary measure of poverty, the ones that is mostly used. This interesting graph shows that extreme poverty continues to be overwhelming in rural areas, where the rural areas account for 4 out of 5 people who live in extreme poverty. As you can see from the chart, almost in all regions, except the OECD countries, the share of poverty in rural areas is much higher than the share of the rural population in the regions. So you can see that the global average is about 80%. And then you can see in South Asia and Sub-Saharan Africa where this share is even higher. There is something more than this graph shows, that there is also this poverty has become even more rural between 2015 and 18, which are the latest estimates, the share of rural population in the total population of poor increased by more than 2 percentage points during this period. We also know that the COVID-19 pandemic is affecting a lot poverty in rural areas, and overall poverty and unemployment rates are increasing because of COVID, we have potential for deepening rural poverty due to lack of remittances, blocked supply chains of goods, and basically the informal economy that is based that is the basis of the rural areas is increasing this gap. We move now to the next slide, which so we are still talking about poverty, but here we are talking more about the multidimensional poverty and the deprivation. This is very important for building rural proofing and intersectoral policies that Theodora was discussing earlier. So even here you can see that multidimensional poverty also more intense in rural areas. Of the 1.3 billion people who are multidimensionally poor, 1.1, which is equivalent to 84%, live in rural areas. We also see that in low-income countries, analysis of recent surveys indicate that every 100 urban residents complete the secondary school, only 23 rural residents do so. So there is a big gap in rural areas also in terms of education. This graph is focusing on the prevalence of stunting, which shows that the prevalence of stunting is 34% in rural areas against 20% in urban areas. And we know that nutritional status and dietary habits are often worse off in rural areas, and this is important to be considered in order to build rural proofing and intersectoral policies. This of course shows the overall index, but it's even more important to look at the different components of the multidimensional poverty, because only in this way we can work together across UN agencies and national stakeholders to design the adequate response. I have in my last slide, I have the pleasure to present the latest the results of the latest report that FAO, IFA, WHO, World Food Program, and UNICEF just presented 3 days ago. This is in this graph. I'll present the gender gap in global food insecurity and COVID and the impact of COVID-19. In particular, I'll focus on SDG 2.1.2, which is based on the food insecurity experience scale measure developed by FAO. As you can see, this indicator is measured since 2014. At the first glance, this graph seems a bit complicated, but you can see that for each area, in each column, you'll find 2 pairs of graphs. The lower pair refers to severe food insecurity, and the higher pair refers to moderate and severe food insecurity. In this case, we will see that the pandemic in the last year, in 2020, has increased the gender gap. And basically, this is mostly due to the increase in Latin America and the Caribbean and Asia. And you can also see that this gap is higher for the middle class. So apparently the COVID-19 is exacerbating the gender gap in the middle class, particularly in, as I said, in Asia and Latin America. Although, as you can see, women are always more food insecure than men across all the regions. It's also important to mention that in this report, the statistics are not disaggregated by rural-urban, but from our analysis that we have conducted in separate papers, not presented in the report, we also show that when we look at the intersectionalities of being women and in rural areas, we see that women in rural areas are much more food insecure than men. We also have seen that rural and women tend to be disproportionately affected by health and economic crisis in history. And this graph also confirms that even during this health crisis, which has also become an economic crisis, is widening the gender gap. And this affects, and it's not limited to food insecure nutrition, health, the time burden of women, and also the productive and economic dimensions of, and these are all important elements to be considered in when we design both health and social and economic policies in rural areas. Thank you very much for your attention. I'll give now the floor to Ndaya Belchica from IFAD.
Thank you so much, Jürgen. It's my pleasure to be here. Good morning, good afternoon, and good evening, colleagues. We have just seen and heard that poverty, multidimensional poverty, and inequality are more intense in rural communities. So in other words, overall, when compared to the urban poor, the rural poor have less access to basic and productive services, and this undermines their basic human rights, development, well-being, and participation in political processes. However, when we talk about the rural poor, the majority of whom is poor and at risk or at risk of being poor, we refer to different subgroups as noted on the slide, each with its own specific vulnerabilities. Having said this, many are affected by several of the following sources of inequalities. So when many of those people, they have unequal access to resources such as income, land, input, capital services, or health and education services as well. And therefore, they also have limited access to how they use these resources and how they own those resources. They are also mostly affected by the lack of ability to cope with environmental degradation, climate change, and extreme weather events. In many instances, their social relationships and networks have been strained by poverty, lack of opportunities, outmigration, gender inequalities, discrimination, or other historical factors such as colonialism or feudalism. The lack of public services or the inadequacy of public services in rural areas also jeopardize the key rights, such as the right to healthy and adequate and nutritious diet, the right to education, health, social protection, the right to cultural life and leisure, as well as the access to water, sanitation, and access to safe and remunerative work. Those inequalities and inequities also increase the risks of violence and tensions in the rural communities. Next slide, please. So now when we pursue an equitable and inclusive rural proofing agenda, the rural proofing as defined by Theodora before, to enable all the rural people to fulfill their human rights, we can consider a broad range of services which can be grouped in 4 categories. So starting from the top clockwise, we have a set of services with the purpose to ensure the development of human capital, which in turn will lead to economic development. For instance, evidence has shown that when rural people engage in agriculture, have access to agricultural and services such as advisory services, finance, business development, energy access, or market support, they are able to increase productivity and profitability, manage risks, and diversify into more productive income opportunities to move out of poverty. Secondly, we can see that if we look at the second set of services, which fall under the category of social inclusion, these have the aim to promote the development of social capital and well-being for all, because it realizes that agency, empowerment, and health is key actually to break the cycle of intergenerational poverty and inequities. For instance, today, more than 70% of the world's population have no or limited access to comprehensive social protection. And coverage in rural areas is even lower, in particular for the rural or marginalized groups. Measures to ensure food and nutrition security, as well as health services, should be essential in social protection. This is particularly important for people working in agriculture because, as we just saw, they often have low and irregular incomes and face high level of poverty, malnutrition, and poor health. Thirdly, we have the services linked to the environment. Those are to close the gap in coverage in natural capital as well as resource management. For instance, in many countries, the provision of reliable and effective infrastructure in rural areas remain a major challenge. Now, if we focus on water and sanitation services, we know that approximately 8 in 10 of people worldwide who lack access to basic drinking water service live in rural area. And out of that, 7 out of 10 people of those lacking basic services, we also have 1 in 4 billion people collect drinking water from fecally contaminated water. So we know, and then we have documented that water and sanitation safety planning could reduce that number and also reduce the burden of disease from waterborne pathogens, while at the same time protect the environment. So although we have all of those 4 categories that I just mentioned, those are very much linked. Lastly, we have the services to ensure equitable political capital and effective governance. For instance, rural people experiencing poverty, as we have seen and discussed in the previous slide, in particular, women, youth, indigenous people, and other marginalized groups, generally have weak or unprotected tenure rights and insufficient access to well-functioning and efficient land tenure services. In some areas, this is compounded by increasing population growth or rapid urbanization or climate change. Evidence has shown that land tenure services combined with access to information, extension services, as well as market-oriented services would enable greater agricultural productivity, food security, as well as access to market, and this would be linked to improved economic outcomes. This also would contribute to the empowerment and would at the same time prevent some conflicts and could also reduce migration. So now as an introduction to the brief that you would see, along with the discussion on the manifestation and the causes of inequitable access to public services or coverage within rural areas or between rural and urban areas, we also have discussed the equitable and inclusive access or opportunity for rural proofing in the forthcoming report that you can see on your right. So this report would explore the different opportunities that would have a multiplier effect across a number of social domains. This report would also inform any future work that we hope to be able to capitalize on between the different UN agencies. And with this, I will pass the floor on to Theodora. Over to you.
Thank you so much, Nadaya, and also Ergen. Now, building on your overview, I'm going to now bring us all back to really focusing on some key questions that we can dig deeper on in the context of today's webinar. And these are, in which ways could rural proofing of national health policies, strategies, plans, and programs contribute to the reduction of health inequities in rural areas and building forward better for the rural poor? How is rural proofing now being used in different country contexts, and what are the challenges and successes? How can rural proofing across sectors help address social and environmental determinants of health in rural areas in support of multi-sectoral transformative rural development plans, as Nadaya was just presenting? How can the rural poor, as well as health workers, be engaged in rural proofing? What evidence is needed to feed into rural proofing for health from both within and beyond the health sector? And how can we better take a people-centered, integrated territorial approach that accounts for mobility and connectivity between rural and urban areas, a bit breaking the rural-urban dichotomy that's now very present in the development discourse? So these are key issues that we'll look at across the speakers today. We'll start with a panel with country experiences. We'll hear from South Africa, Russell Rensburg, from United Kingdom, Brian Wilson, as well as Josefina Montero from Chile. The first two will focus very much on the health sector, and the third will look at a cross-sectoral approach to rural development that really focuses on inclusion and let's say it shows entry points for rural proofing across sectoral domains, which would also serve to address many key determinants of health. Then we'll hear from Ana Moreno Monroe from OECD, who will talk about the OECD principles for rural policy and rural proofing of sectoral policies. And she'll also discuss some recent work on delivering quality education and healthcare for all. Then we'll hear from Kira Koch, who will present on the UHC Social Participation Toolkit and how it can be used to support community engagement in rural proofing. And she'll be looking at issues such as equitable opportunities to participate, capacity building for participation, and then also linking participatory rural proofing to the population consultation phase in national health policy strategies and plans. Then to wrap up the webinar, we'll be hearing from Bruce Chatter from the Wonka Rural Working Party, who will talk about rural proofing human resources for health policies and health workforce pipelines, the role of health workforce initiatives in contributing to rural proofing of national policy strategies plans. And he'll also give us a preview of the upcoming topics in this webinar series, which are all relevant to and contribute to rural proofing. So I'd like to now ask Russell Rensburg to please get ready to present. I'm just going to stop sharing this presentation and load his. So if you please give me a moment. Okay, I see that Russell's presentation is loaded. So please go ahead. You can present, Russell. Thank you.
Good afternoon, good morning from a very cold and conflicted Johannesburg. My name is Russell Rensburg. I work with the Rural Health Advocacy Project, which is the division of its Health Consortium and was founded by the Rural Doctors Association of South Africa, the AIDS Law Project, now known as Section 27, and the University of Witwatersrand's Center for Rural Health. We can move to the next slide. So just a little bit of a country context for South Africa. South Africa is a constitutional democracy, and what that means is that, you know, the highest law in the land is the Constitution, and it's meant to guide how the government works towards progressively realizing the rights laid out in Chapter 2 of the Constitution, which includes the Bill of Rights, which included in that is the right to access healthcare services for all. Healthcare delivery in South Africa is governed by the South African National Health Act, which provides the regulatory framework for delivery of healthcare services in South Africa, both public and private. The responsibility for health is shared between the National Department of Health and 9 provincial authorities, with the latter being responsible for the delivery of publicly funded healthcare services. The public sector network or healthcare delivery platform is coordinated through a district health system, which includes a network of over 3,500 primary healthcare clinics and district hospitals. These are augmented by a network of specialist hospitals, regional and provincial hospitals. The South African health system, both public and private, is still very hospice-centric, with over 61% of provincial health budgets spent on hospitals. South Africa also has a very large private healthcare sector that roughly spends about the equivalent of what we spend on public sector or publicly funded healthcare programs. despite only servicing 16% of the population. The next slide. In our current context, it's difficult to talk about South Africa or South African healthcare or even rural proofing without considering poverty and inequality. Over the last couple of days, I think global television screens have seen some horrific shots of what's happening in our country with coordinated looting efforts and a country that is really in the grasp of fear. But many of these things have been spoken about and theorized for a long time, with South Africa having amongst the highest Gini coefficients in the world, which measures the levels of inequality. The bulk of that wealth is concentrated in the large urban areas, and while our average or national per person income may seem high and qualify us as a middle income country, relatively speaking, South Africa is actually quite a poor country the further you move out of the urban areas. Structural unemployment is a key feature of the South African labor market, with up to 60% unemployment amongst Black youth. And that's just on official measures. So it doesn't count people who have stopped looking for jobs. When you look at rural youth in particular, which make up the large percentage of South Africa's rural population, is almost 90% unemployment. So 38% of the population, is close to half, live in rural areas. And many of the urban poor often have rural origins, sometimes 3 times or 4 times better than their rural counterparts, even though income levels are still relatively low. But not all rural is the same in South Africa, and not all rural is necessarily agricultural or are linked to agricultural production systems. Right? Rural and underdevelopment sort of goes hand in hand in South Africa, where we've had 10 what we call former homelands of Bantustans, where during the apartheid era, many of the country's previously or currently disadvantaged populations were forced to live. The COVID crisis, while it hasn't impacted rural as hectically as elsewhere, relatively speaking, many of the challenges that the healthcare system is facing in urban areas have long been challenges in rural care, particularly things like access to oxygen and access to all the healthcare services that are needed to treat the population where they are when they need it. But COVID has a long tail, and with healthcare services in South Africa being publicly funded, the impact on future healthcare delivery is significant. With the government's expenditure on healthcare being close to 16% of total income. But as income drops, what's available to spend on healthcare will reduce. And if previous experiences in to go by, this is likely to impact the rural health systems and those in former homelands disproportionately. Next slide. RAP's approach to rural proofing. We obviously got introduced into RAP was founded in 2009. And as we sort of went out and tried to create a framework to lobby the system or to advocate for a better response to rural, we went through various steps. The first step was obviously trying to identify rural. And as I indicated in my first slide, rural, it's not a cut and dried kind of solution. Rural is often not being urban, but the broader determinants of health and well-being are not the same across all rural areas. You could have an average spend in a rural area like Cathcart, which is in the Eastern Cape, which is, let's say, $800 per day or per patient day equivalent, versus a third of that, just maybe 200 or 300 kilometers as the crow flies, in a rural formerly known as Transkei, where spending is significantly lower. So how we try and figure out rural deprivation has been really difficult. And I think to date, we haven't really got an operational definition of rural that can act as a catch-all. We also have a situation where we have a lot of small rural towns in the former provinces where a lot of the urban challenges around access to healthcare are amplified by sparsity. These systems being far away and having to deal with urban problems like gender-based violence, access to mental health care services, substance abuse, and all of them far away from the system's capacity to be able to support it. Our rural approaching, from there we worked out, we put together a guide along with our partners at the Rural Doctors Association of South Africa, that was based on the WHO Health Systems Components Framework. And through that guide, we tried to popularize the consideration of rural in national health policy and planning by looking at those 6 components and showing the extent to which rural inequalities are higher than elsewhere in the country and the need for rural specific solutions. One of the big benefits of the guide was that we were able to use that guide to inform with our partners RAP and the Rural Network's response to the national health reforms, proposals currently located within what they call the National Health Insurance. And a lot of this guided our submissions. And I think for the best part of many of the submissions that we made were considered. And we feel that where the system is going now with more decentralized health planning would be one of the best ways that we can deal with rural health inequalities. We've also trained a number of district management teams who are responsible for delivery of rural healthcare services in their districts around this guide and how they can apply it to better allocate resources to rural responses. Now, while the guide has been largely accepted and agreed with and cited in government policy, our attempts to institutionalize the guide as a planning framework have been a little bit limited. And because South Africa applies a very top-down planning approach, where plans are made at a national level and then often just evolved and adjusted at the local, provincial, or district level, with very little consideration for the implementation context or to applying some management practice in terms of setting priorities for the districts where we are. And I think this is probably the next set of struggle that we hope that reforms such as the NHI will allow us to advocate for more intentionally in rural districts. Next slide. We've adapted, and based on this, and particularly around the introduction of austerity and also looking at the impacts of COVID going forward, we had to refine our approach a little bit, and I think we're in the process of doing that a little bit more intentionally. As I stated earlier, healthcare services for 85% of the population is funded by the national government, but extended periods of low economic growth, increased debt obligations, or poor use of debt have resulted in healthcare expenditure in the recent years, over the last 9 or 10 years, not keeping up with population growth or health need. While planning is well developed, implementation and monitoring of those plans is particularly weak the further you go down the health distribution or health delivery networks. The NHI, or the National Health Insurance reforms, as we understand it, is a district-based approach, and it offers an opportunity to show greater rural need by making the planning and delivery of healthcare services more orientated around the implementation context that they face. So part of that struggle is that we've been able to, but I'll go into that in our successes in the next slide. But in response to these crises, I think we've sort of worked on a more refined approach to rural proofing. And I think in the near term, what we're looking at is sort of deconstructing inequality within rural and in the country more generally. And through that, we are placing greater attention on understanding health management information systems and the extent to which they provide the kind of data and intelligence that allow for better decision making at the local level. We've looked at human resources for health in particular. South Africa, on an aggregate level, has actually quite a good ratio of healthcare workers to population, but there's a maldistribution of talent relative to where the need is. And with rural systems being so difficult to resource, we find that the distribution is in favor of urban areas, and we need to find different ways of recruiting and retaining healthcare workers into the rural system. But to do that, we need better data and better prioritization, which is some of the elements that we've taken through in the development of the most recent South African National Strategy for Human Resources for Health. And the last aspect we're looking at is just really the efficiency of spend and the extent to which health financing in the system responds to where the needs are. In an earlier slide, I indicated that because of infrastructure and equity traps, or the way that we've transformed in the last 27 years, we tend to spend a lot more money on maintaining hospital systems and very little on primary health care, which is the area of healthcare which is often the most accessible and the easiest to expand, to the detriment of the populations that we're trying to serve. In recent years, we've actually had a drop in utilization at primary healthcare, from a high of 3 visits per year to now just over 2 visits per year per person. But the lack of intelligence or lack of analysis of our information systems has meant that we're not really delivering or spending the money that we have efficiently. And then lastly, looking at values and leadership, I think a lot of our rural proofing work now is locating the right to health for rural people as part of a broader societal response to addressing inequality by exceptionalizing rural inequality and the extent to which the current institutional frameworks actually discriminate against people based on their geography and where they live. Next slide. Some of our successes. As I've indicated, resource allocation in the public sector is really just driven by like nationally based formulas. Over the last while, we are in the process of revising the way we distribute money to the provincial entities through something called a provincial equitable share. And then also we're having some reforms in terms of how that money is translated from the provincial to the district level. And in redoing those formulas, we've now successfully included additional indicators to adjust for the rural context. These include indicators on sparsity, because rural areas are often remote and don't always have the economies of scale that allow for effective healthcare utilization. Including in that, we've also added in the risk adjustment an indicator for premature deaths or premature mortality as a proxy for unmet need. And in that way, we feel that hopefully through this, we can see better resource allocation to rural districts. In the development of the most recent strategy, we've also successfully advocated for the inclusion of indicators to address the maldistribution of human resources for health. And what we did there was really get the system to introduce a measure of inequality insofar as how healthcare resources are distributed within the public sector. And what we did was we proposed that we sort of start with a baseline where we would like all provinces to get to sort of the third best province in terms of equity. And then what that will require is really just a change in the way that we fund healthcare and using approaches such as the annual community service allocations to address some of this maldistribution by ensuring that healthcare posts are prioritized in areas that fall below the third best equity indicator. In terms of inclusions of rural proofing approaches in key policies such as ward-based outreach teams, where we've successfully advocated for the composition of those teams to be contextually driven. So where in rural areas, we would have more teams covering a broader group of areas, and we're currently working hard on having those guidelines implemented. And then on a more software kind of, as advocates, we're lobbyists and agitators. So from the lobbying side, we work with inside the system, where we use our networks to try and influence policy. And then on the outside, we work on mobilizing civil society that operate within healthcare and within the broader determinants of development around the particular need to prioritize rural. And then lastly, I think one of the things that we particularly are excited about is that we're now currently working on developing a rural business case for rural contracting units for primary care as part of the national health insurance reforms. Under this proposal, we've got agreement from one of the provinces and the national government to work with 2 rural hospitals on the design of a care network in the rural districts that is centered around the district hospital as a hub. And we hope within the next 6 months, we can have the completed business case. And once that business case is approved, we hope that we will have the introduction of a rural health pilot that will test the extent to which the changes in the institutional arrangements can lead to the better delivery of care. And lastly, and next slide. I think what the biggest challenge for us is really just to look at all of these intersectoral challenges, and how we can better link health, not just to healthcare, but also to articulate health as an enabler of development, as something that can contribute to addressing a number of different SDGs. And I think just in terms of gender in particular, how access to comprehensive reproductive health services can really enable women and young women in particular to live their best lives and not have them interrupted. Sadly, in rural areas, teenage pregnancy is amongst the highest, and the support networks that are available to those young women are the lowest. So I think there are just some priority indicators that we need to look at in consultation with our partners that can make the biggest impact to improving primary healthcare services at the local level, and hopefully build on that by establishing more efficient referral pathways to ensure that the resources that we are spending are done or are allocated in a manner that can contribute to the greatest good. Thank you. Over.
Russell, thank you so much for the excellent presentation. It's really exciting to hear about your work and also what's on the horizon with regards to the National Health Insurance Reform. So I'd like to now, in the interest of time, move to Brian Wilson. Brian Wilson is a senior research consultant specializing in rural policy and rural development. He is also director of Rural England CIC, a nonprofit organization that seeks to improve the rural evidence base and its application within policymaking. And Brian will present the latest version of the Rural Proofing for Health Toolkit, published in December 2020. And the tool is aimed at helping organizations in health and care sectors to address the needs of their rural populations. Please, Brian, go ahead.
Thank you very much, Theodora, and thank you for the chance to present the Rural Proofing for Health Toolkit, which, as you say, was only published in December 2020, so it is only 7 months old, although it does replace an earlier version which had become out of date and which I wasn't the author for. It is worth saying, because I know you've kind of put me down as United Kingdom, that the toolkit really is designed for the health and care system in England. We have a slightly different, the management and structures are slightly different in the rest of the UK, in Scotland, Wales and Northern Ireland, although admittedly not that different. So our toolkit is aimed very much at the local or regional or sub-regional level rather than the national level. And it aims to help organisations and indeed partnerships in the health and care sector to address the needs of their rural populations when they're developing policies or service delivery plans. And I think the important point I'd make there is we think that rural proofing is only really successful when it's very much an integral part of that policy making process. It's not impossible to use it once a policy's been designed, but I think retrofitting of rural proofing is certainly less successful. So it needs to really happen as part of the process. And it aims to tackle a number of rural challenges which are faced both by users and providers of health and care services. I've listed a few there. You'll probably recognise them. There are certainly issues of accessibility for rural users. There are various cost issues and indeed various infrastructure issues such as lack of public transport and poor digital connectivity, which is increasingly an issue, I think, on this agenda. One thing I would stress, though, is that for us, rural proofing isn't just about tackling challenges, it's also about realising opportunities. And I think it's a point we make frequently with the toolkit. And to that end, the toolkit includes a number of rural case studies and indeed sort of various lists of other ideas and suggestions that users might want to consider. The structure of our toolkit is outlined here. As you can see, it's based largely around 6 main themes. These are sort of the core chapters, if you like, in the document, and they're quite wide-ranging. They include services which are delivered through our National Health Service, the NHS, so hospital services, primary care services, things like that. But they also include services which are largely delivered by local authorities, such, or I say delivered, largely funded at least and managed by local authorities in England, such as social care services. So it's got quite a wide target audience. And there is one theme which you'll notice isn't sort of one of the subsectors of health and care provision. We've got workforce in there as a separate theme, because recruiting and retaining staff is a significant rural issue in our country, and a long-standing one. There are also some cross-cutting themes within the document, issues that pop up in each of those chapters, and for the most part, you could describe those as issues which are driving healthcare reform in the UK. So we're very keen that the toolkit sort of aligns with those various agendas, and see, to make it seem really relevant. I said just now that rural proofing isn't just about tackling challenges, but is about opportunities as well. And one of the points that we are constantly trying to get across is that rural proofing is a positive thing. There have been problems in the past, I think, with people seeing rural proofing as something negative, something additional that they're expected to do, and just sort of a bureaucratic hurdle that they have to jump over. And really, we're very keen to sort of stress the positive. If you said to people, if you or sort of a health organisation, do you want to rural proof? The answer may or may not be yes. If you said to them, do you want to maximise your service outcomes? We know what the answer would be. Do you want to take advantage of innovation? Yes, they certainly would. So I think we're very keen to stress that rural proofing is something that can help them achieve these various other benefits, such as optimizing outcomes and tackling inequalities. And I was asked to highlight some of the factors that either block or facilitate rural proofing. And I think those are both policy issues and process issues. Certainly, in terms of policies, one of the key challenges I think that we do have is that quite a lot of hospital services have been centralising, so that the health system can form more specialist units that admittedly tends to generate better health outcomes. But of course, that then creates access issues for rural people who don't live near a main hospital. So centralisation is certainly one of the blockers. On the other side of the equation, I think it's fair to say that there is a push to have more sort of more regular health services available locally at what we call health hubs sometimes, or outreach clinics. So that really is an opportunity for rural proofing. Another big blocker, I would say, and I've called it understanding here, in my country, only 17% of the population lives in a rural area. So there is a bit of an urban mindset amongst policymakers, and just really getting an understanding of rural issues, some of the rural challenges, getting that across really and onto the policy agenda is itself quite a major challenge. And I have flagged here that there are obviously other higher profile issues at times, not least at the moment, the pandemic. I was also asked how rural communities might be involved in rural proofing, and I think they certainly do have a potentially really useful part to play. I've got a sort of we have a little chart in the or graphic in the report which I've put here, which in essence shows sort of how rural proofing fits into the policy making cycle, and I think there are various ways in which public or input community input can be useful, not least because rural areas are very different from each other. So rural proofing mustn't just sort of generalize and take all rural areas to be the same. And I think that input from communities, from the public, from patients, is really one way of understanding those very local factors. Certainly, we think they can input through public consultations on health reform. It should be fairly straightforward to identify the rural responses. We have patient participation groups quite often who are essentially users of specific health services. Again, it's possible. It would be possible to make sure there are rural users of those services in those groups. And then we have what we call local health watchdogs, Health Watch, who gather feedback from users of services and feed that back into the system. So again, they could certainly gather rural findings. I think all those things would be useful. Finally, I was just going to mention the COVID-19 experience in my country. Initially, there was quite a lot of concern about the situation of rural areas because the population is on average older in rural areas, so clearly there was a higher risk in those terms, but also there is less capacity in the health system in rural areas. So there was a real risk that hospitals and GP surgeries would become overwhelmed much more quickly. I have to say the experience so far, certainly from the data, is that rural areas have fared relatively well, at least. Obviously, we've had some pretty dire figures nationally, but in relative terms, rural areas haven't done too badly. The infection rates have been lower, vaccination take-up seems to have been generally higher than in urban areas. And one thing that we've really noticed is that a lot of community groups have formed very early on when the pandemic hit to support their vulnerable and older residents, which was that was a particular feature of rural areas. But rural proofing can certainly contribute towards the rebuilding of rural health systems as we come out of the pandemic. And in many two instances, I think I've just listed 3 things here, but in 2 of those instances, I think really it's just about making sure that rural people have reasonable access or better access to those services. That's mental health services and public health initiatives. Both of those tend to be predominantly urban based. So really making them more accessible and locating some of them in rural areas is certainly something that rural proofing could contribute towards. The other thing I would stress really is that I think there is a real chance to try and retain some of those community groups. If they could be kept going, they would certainly help support the well-being of older and vulnerable residents in rural areas. So I think my time is probably up, but the toolkit, which you see on the right there, is accessible if you'd like to see it online, and it can be found on 2 websites, both my own organisation, Rural England, CIC, and the National Centre for Rural Health and Care, who jointly funded it with us. Thank you very much.
Thank you so much, Brian. It was great to see the facilitating factors and also the bottlenecks. That was very insightful, and also your indications of how communities could be involved. And also the fact that you include social care services as part of the approach. So thank you for covering those issues and presenting the handbook. I'd like to now hand over to Josefina Montero. Welcome, Josefina. We're honored to have you with us. So Josefina Montero Reyes is head of rural development, the head of the Rural Development Department in the Office of Agricultural Studies and Policies in the Ministry of Agriculture of Chile. And she is an agronomist with a major in administration of the Pontifical Catholic University of Chile. She is speaking about the Rural Development National Policy and its 4 areas of work, which are social welfare, economic opportunities, environmental sustainability, cultural and identity. So please, over to you, Josefina. Thank you so much.
Thank you very much, Theodora. Good morning, good afternoon, good evening to everybody. I would like to start this presentation giving thanks to the World Health Organization for this invitation. It's an honor to us to be here and share with you our Rural Development National Policy, a result we are really proud of after several years of work. I will start sharing with you the current strategy that we are working on the Ministry of Agriculture. It is based on a sustainable agricultural and forestry activity. And this means that there are 3 important aspects contemplated: economic, environmental, and social. So considering this strategy, we realize the urgency to have our Rural Development National Policy, which is a key instrument when we are talking about sustainable territories. Furthermore, an important part of this strategy is the collaborative work and construction between all the actors, the civil society, the public and the private sector, because each of them play a fundamental role in the territory. In this presentation, as Theodora said in the beginning, I will show you a little bit big scoop of rural development. I will show you a glance of the rurality in Chile with some details of the rural health. I will share our actual Rural Development National Policy. And finally, I will emphasize in the big challenges that we have as a country related to rural health. As you know, Chile is a long country that hosts a rich variety of landscapes, each one with its own characteristics and particularities, starting with the desert, going through fertile valleys in the center and ending in the extreme Patagonia, and all of these territories are surrounded by the Andes and the Pacific Ocean. The 83% of the Chilean surface belongs to rural and mixed municipalities, making it clear that we are a rural country and it is urgently required a policy that addresses the work in all of these territories. In relation to the Chilean population, according to the OECD measurement, which was adapted to the conditions of our country, that 25.5% of our national population lives in rural areas, making it clear that a rural national policy would be addressing a quarter of the Chilean population. Here we can see some of the gaps that we are seeking to address with our rural policy, and also we are starting to build a rural proofing, which will make all the other ministers work in rural territories. So you can start seeing that only the 16.8% of rural households have a broadband connection, something that has been visualized during this pandemic because of the need of connection for education, work, health, among other services. The 54% of the rural population does have access to drinkable water. In urban territories, this is the 98%. and that 26.8% of rural homes does not have an acceptable building materiality. Now, if we stop and check to our rural health indicators, we can see that in rural municipalities, there are half doctors available per 100,000 inhabitants than in urban municipalities. And also, only 1/3 of the rural population can access a healthcare center near their homes. And finally, it is very difficult to find in rural territories complex hospitals or critical beds, so rural inhabitants are forced to move to urban sectors to find these services. However, rural territories are a space of opportunities for our country, where we can promote the decentralization through the regional development, move towards a greater territorial equity in relation to the urban sectors, value the diversity and promote a productive development in a context of water scarcity and climate change. And finally, develop collaborative work in the public sector, equalizing opportunities throughout the country. During several years, our country made efforts to elaborate a rural policy, but it wasn't until 2020 that we finally had an official rural development national policy. So after several years of work, research, participation from all the regions of our country, and an OECD review, in 2018, we had this new opportunity to finish the work we had begun. We created the Rural Development Department, which oversaw updating the rural policy and incorporating proposals from the civil society. The result of this work was the official publication of our Rural Development National Policy on May of 2020. The result of that work is our Rural Development National Policy, which it has 54 guidelines to improve the quality of life and increase the opportunities of the rural inhabitants in Chile. It has 4 areas of work. One of social welfare, which seeks to reduce the gaps for accessing to goods and services. Other one of economic opportunities, which seeks to improve local performance and dynamism. The area of environmental sustainability that values the natural landscape and manage their associated risks. And one of culture and identity, which aims to protect and promote the tangible and intangible heritage of our rural areas. Finally, there is a chapter on governance that define the guidelines to work between the different administrative levels to have a successful implementation of the policy and get to work into the local territories. One of the fundamental aspects of this policy is that it involves the coordinated action of 14 ministries. Each of them plays a fundamental role in the development of rural territories, and they are part of the ministry's committee. Also, it had just been constituted a national council, conformed by actors from the public and private sector, the academics, and civil society, that represents the different actors of rural territory and that seeks to the implementation of the rural policy. In the regional level, the regional governments must incorporate the rural policy guidelines in the regional strategic instruments, just like the local level, where the municipalities incorporate the same guidelines in their local planification instruments. From the Ministry of Agriculture, we seek to generate this important articulation because the rural inhabitants need education, healthcare, energy, broadband connection, transport, financing instruments, mining policies, among others. And we cannot do all of this from the Ministry of Agriculture. We need to work together. And finally, to end my presentation, as you may have perceived, we have many challenges on reducing gaps to access different services, including healthcare. So related to the rural health, we can see 3 big challenges. First, the obesity. The 33.6% of rural inhabitants are overweight. and that is related to their consumption behavior with a high consumption of sugars and sodium. Second, the medical specialties. The rural municipalities lack of specialists, so many of their inhabitants cannot get a detailed diagnosis, and usually they must travel long distances to find the correct professional. And third, the digital connectivity. The access to a quality broadband and internet connection can bring access to many services like telemedicine, giving solutions to the second challenge mentioned. We hope that with the implementation of our rural policy, and indeed with a rural proofing, we can address a better healthcare service to all the rural inhabitants and also have better information with the indicator systems that was built to measure the rural quality of life. So thank you very much for this opportunity, and I'm available of any doubt, questions that you may have.
Josefina, thank you. It's really exciting to see the potential for this strategy to tackle social determinants of health and how it's really looking at inequalities across sectoral domains, which will in turn benefit health. And it's interesting to hear also how you'll be supporting rural proofing across different sectors. And the governance also lines that you've set in place across the different levels, backed by the indicator system. So it sounds like an area that has great potential, and I'm looking forward to following it in the years to come to see how it further rolls out. Thank you very much. I'd like to now turn to our next presenter, and this is Ana Isabel Moreno Monroe from OECD. She's an economist at the Center for Entrepreneurship, SMEs, Regions and Cities at OECD. Previously, she worked as visiting assistant professor at the Autonomous University of Barcelona and as the Marie Sklodowska Curie Fellow at the Roveri i Virigi University and the London School of Economics. And Ana will present on how rural proofing of health sector policies is a powerful way to tackle structural inequalities in access. Also, she will speak about the main obstacles for coordination between rural and health policies and the way forward based on current OECD work. Ana, over to you, please. Thank you.
Thank you, Theodora, and hello, everybody. It's a pleasure to be here. This is going to be maybe a higher level reflection on some issues following the excellent presentation we just heard. I'll touch upon many topics that have been mentioned before. And as you said, Theodora, at the beginning, on a recent report we had on delivering services, I will put the link to our work stream on this area so people can learn more about that report and other work that we're doing. And we will also upload the slides that we'll present today in the event section on the website. But for now, next, please. I can start with this graphic that is from the delivering report that you show at the beginning. We are thinking the problem of service provision and health care service provision, in particular, in this trade-off between these three dimensions: cost, quality, and access. So when we look at rural-urban gaps along the three dimensions, we find that rural areas in OECD countries perform worse than urban areas across the three dimensions, as you say there, in access, for instance, a longer distance to care, less hospital beds per capita, and cost, higher costs that are related to the issue of low scale that was mentioned before, and on quality, many indicators such as lower prevention rates and lower survival rates. And here we call it a trade-off because we see that policies can have impact in some dimensions and affecting others. To give you an example, for instance, concentrating health provision in a bigger hospital in a city can decrease cost because you increase the scale, and can increase quality because maybe you have better professionals and you build on the expertise to provide better care, but that will affect the access dimension. So there's always a trade-off between the three dimensions, and it's the role of policy to balance this to preserve both efficiency and equity in provision. Next, please. And here, looking at it from a different point of view and coming back to some things that were mentioned before, if you think of from a sectoral perspective, that is usually the way these things are thought of the provision scale, for instance, there are many debates about how you divide these things, but if you think about a primary care, when you have lots of demand, relatively low cost, with lots of frequency of needs, then you have on a bigger scale specialist care that require, more refined skills and probably higher scale to provide. And then lastly, acute care, when you don't have so much demand, but the complexity is very high, so demanding very specialized skills. So this has a matching with the spatial scale, because if you think about it, primary care, it's the service that will be accessed by most of the population that lives sparsely in territory. So this includes the rural population that should be present there because of this frequency of needs. Then you have the other scales that will probably be placed in already settlements that have high enough demand to ensure the scale, and then the very specialized services probably in the largest cities where you can attract specialized workers, etc. So it sounds very logical, but usually the way health systems are set up does not have necessarily what we call a place-based view. So it's planned from the sector level, but not from the spatial level. So there could be a mismatch on the way these policies are carried out. And we already heard from Russell in South Africa. This is exactly the point that, you concentrate, but then at the same time decrease primary care provision. So then you're affecting the equity from the point of view of access to primary care. Next, please. So, and also here coming back to some more refined approaches to service provision that is very connected to the presentation of Brian of, how do you get out of this problem of small scale and the fact that providing in rural areas is more difficult and that you have gaps to start with. And here we have the example, for instance, of Japan, that did a policy that was multi-sectoral and cross-governmental levels to organize the territories around service provision, not only taking into account the specific healthcare, but also another variety of care services that could be complementary and that would be part and even go beyond primary care provision. And here they had to do this rethinking also their future of rural areas, because they saw population declining, population aging, and had to rethink how would the settlements make sense for the future. So how can we do a strategy today to reorganize territories? So they had this model of compact and networked towns, and here with towns with different functions and serving complementary purposes, ensuring access and making the most of the scale at the lower level, for instance, by combining different services, something that France has also done in the Maisons de Santé. Next, please. The problem here, this sounds all very nice. The problem is that this kind of effort requires a very strong governance work behind. And Josefina already mentioned some of the things that Chile has done to align everybody on the same page for the provision of services, but it's not an easy task because we work on sectoral silos and all the political issues involved with the rural versus urban debates. So here, what we frame this work on is this more general framework for rural development that it's part of our recent publication, Rural Wellbeing Geography of Opportunities. You see there are many things that were mentioned before, for instance, the need to differentiate between different types of rural areas, not have one single rural-urban dichotomy view, the need to always promote an integrated rural development approach, and the need to have data from multiple sources and multiple angles to understand how rural development is evolving. But specifically, I wanted to focus here on this difference between a top-down kind of sectoral approach to policies to the bottom-up approach that also builds on local strategies and that needs the integration of multiple policy domains. So here, the whole topic of rural healthcare provision we see from this lens as a problem that needs coordinated action and therefore a lot of work on the governance side. Next, please. And here, just to give you a short example on why we promote this type of things. Usually we see, for instance, there could be an urban bias when hiring doctors, or not enough financial incentives for doctors to go to rural areas. So, for instance, if the government has a policy on human capital formation on the medical personnel, but from the start does not recognize the present and future gaps in the doctors in rural versus urban areas, they could increase the efficiency and quality of the doctors in the country, but through, for instance, urban bias policies, they could contribute to the brain drain of this type of professionals in rural areas. So it's important to consider also the spatial dimension of this type of policies. Next, please. And here, evolving from, let's say, rural equals agriculture type of framework, you know, very focused on food production, that would be the traditional approach. We think of rural necessitating an integrated multidimensional approach that takes into account all of the factors that you see there, the need for diversification, the need for access, skills and human capital, and institutions. These apply to different types of rural that we recognize here, those that are close to cities and those that are remote, for instance. Next, please. And going beyond, actually, if we want, there is a rural proofing enough, going beyond the rural proofing. What we see in our work with rural communities is that it's very difficult to separate the question of present and future provision of services from the question of how will these communities develop sustainably in the future. Because, you know, the problem of lack of economic activity, out-migration only is going to worsen the rural-urban gaps in ways that will be very difficult for policies to bridge. So actually the best remedy for rural-urban gaps is to try an integrated approach for development. And this requires, you know, working on the side of infrastructure provision, human capital formation, and the business environment that ensures, for instance, job creation. The problem is that usually these areas are not very well integrated in policy responses. So if you take the regional scale, it really depends on the country how much things are integrated and how well different levels of governments work with each other and how sectors involved in these things work with each other. So it's what we promote, but we know it's politically very, very difficult to achieve and requires a lot of work, as I mentioned before, to really have the sustained path that ensures the permanent, let's say, closing of these disparities, and not just some remedies that will disappear once the solution is taken away. Next, please. So here, just to finalize, we say yes, rural proofing is already discussed very clearly by different presenters. Would say it's a necessary but not sufficient condition, because it's only the rural view on a specific topic. It might be need to be complemented by a wider view of what's happening with the economic development of the areas. And here, as you saw from the excellent presentation of Josefina, National Rural Policy Framework might be the best way to integrate very well the sector health on a national strategy that takes into account, as she mentioned, the role of different actors. So from the national to the regional to the local, that they communicate with each other and are on the same mindset, so the same framework. Then the need to overcome fragmentations of programs, that is something that we see in rural areas. There might be a multitude of programs, at least in the countries that we work with, but they are not necessarily integrated in a way that makes sense. And we have some examples of countries that have started this journey of having a national rural policy framework, have accomplished it, including not only Chile, but also Finland, Japan, and Poland. And finally, on this point, the very important part of building capacity from the local level, so these bottom-up strategies really work. Then just to finalize here, the need in this rural profit concept and more generally in a rural development strategy, the need to set clear rules and targets at the national level so they can be negotiated. And here, what was mentioned by Brian was very useful, you know, already mentioning not only there is a gap, but what could be solutions and the path that wants to be taken, and in numbers, what does it mean? And establishing the partnership framework across different levels of government, or any actors that are involved in this decision to coordinate the policy making. Finally, the need for data evidence here, evidence-based, not just saying because an area is such and such, it needs extra support. It really helps to demonstrate the needs that arise from the geography and demographic profiles of the areas. And this is something that we have done also in a recent report, started this journey. So I will stop there. Thank you very much for your attention.
Thank you so much. Sorry, I was on mute still, but I think that you've really stressed a very important issue of the sectoral view not being enough, and the importance of framing rural proofing really under the umbrella of a transformative rural development policy approach. And so we can maximize the synergies and the coordination potential, looking at issues of spatial scale. So fantastic. Thank you so much for raising those issues.
Thank you, Teodora. And I noticed rural principles was on the on the title, but I didn't have time to discuss it. But on the slides, I will paste an annex with the explanation of all the principles that are basically the mechanisms through which we're trying to deliver these ideas. Thank you.
Okay, excellent. Thank you. Thank you. Great. So I'd like to now turn to our next speaker. We have with us Kira Koch, who's a technical officer from the Health System Governance and Financing Department here at WHO headquarters. And Kira was very involved in the production of the new WHO handbook on social participation for universal health coverage. And she's also a member of the team that supports governments in their national health policy strategies and plans, including their work on participation and consultations to inform those plans. So I'd like to hand over to you, Kira. Go ahead, please.
Thank you so much, Teodora, and welcome everyone. I'm very happy to be here with you today on this very important webinar. Yes, I would like to focus my presentation today on one key element of rural proofing that has come up already in the very interesting presentations from our previous speakers, and that's the topic of participation as an important element of any policy planning cycle, and how the recently launched WHO Handbook on Social Participation for Universal Health Coverage can be a helpful resource to support community engagement in rural proofing. Next slide, please. So the Social Participation Handbook is a new guidance document that is particularly targeted at government actors across all levels, working at national, subnational, or local level to provide practical recommendations on the how of social participation. So it's about answering the question how to more meaningfully engage with lay people, communities, civil society to elaborate strategies that are more responsive to population needs. And in this context, rural proofing is really about embedding health equity considerations vis-a-vis the rural poor into health policy making. And to achieve the novel goal of UHC by leaving no one behind, it's about ensuring that the voices of people are heard who are traditionally less powerful and influential, such as the rural poor, including, for example, the most marginalized groups, people living in very remote areas, indigenous communities, etc. And embedding their input into health policy is really at the core of the Social Participation Handbook. On the next slide, you will see an overview of the handbook chapters, and these topics really came out when we were analyzing the large qualitative data sets based on the various literature reviews we've done and the case studies. And in the interest of time, I won't go into detail of all of these topics, but I would like to focus on chapter 2, 3, and 4 for purposes of rural proofing strategies. So let's start on the next slide with chapter 2, where we lay down the fundamental premise of the handbook, and that's power dynamics. Power dynamics are ingrained in any country's political, social, and economic landscapes, and they pose or they create unequal conditions for participation because they pose structural barriers to participation for the rural poor, for example. And these barriers are, for example, as we've already heard from previous speakers, low internet connectivity, the fact that most participatory spaces take place in bigger towns and or the capital, which implies taking time off from work, travel costs, etc. So meaningful participation is brought about by leveling out that playing field within the participatory space as far as possible. And what we mean by that is counterbalancing the inherent and ingrained power imbalances that exist in every society for purposes of that participatory space. So we elaborate in this chapter on the notion of a participatory space where the rural poor, who are generally weaker and less powerful, are empowered to the maximum extent possible to express their views and experiences without fear of reprisal or undue consequences. And this signifies also, and that's the difficult part actually, a humbling of voices of those who are usually more influential, such as policymakers and government cadres. And ultimately, and that's what we try to demonstrate, it is beneficial to all participants, especially to those who are used to holding power and influence, as an enabling environment can act as a great catalyzer for the participatory exercise. So for example, for rule proofing, this means to better understand the specific rule challenges and being able to elaborate strategies that more effectively account for rural needs. And then the participatory space really is a very potent tool to minimize the power asymmetries if, and that's a big if, of course, it's designed in a way that counters formal and informal barriers for equal participation. And there are many ways to lend those with less voice countervailing power through thorough reflection and preparation of the participatory process. And one of those topics on the next slide to start with is the very difficult topic of representation and the challenges of finding the right representatives who should be invited and selected on behalf of rural communities. So firstly, it's important to acknowledge, and that was already expressed previously, that rural communities and the rural poor are not a homogeneous group. They have different challenges and different needs based on location, settlement size, etc. And secondly, the issue of representation is closely linked to legitimacy and credibility. The widely held notion being that if those who are part of a participatory process are representatives of whom they are supposed to represent, then they are also regarded as legitimately. And more importantly, the results of these participatory processes are then also seen as legitimate and more likely to be taken up for policy influence. However, the catch here is that legitimacy and representativeness is something that is not an inherent quality of a person per se. It's something that is conferred through a well-designed and thought-through participatory process. And here it's really about transparency. And transparency here means being explicit about the roles of representatives. For example, why is it important for this specific policy question at hand to listen to the experiences and challenges of a rural community leader? So by being transparent and explicit about these roles, we can lend them legitimacy and credibility. And in addition, various format and design of participatory processes can largely then influence the ability for them to effectively take on the representation roles. For example, it might be more apt to conduct a homogeneous group, a focus group with indigenous group that otherwise would not feel safe and comfortable to speak up. And here I think consideration in which language those meetings are being held are also important. And usually a mix of various participatory mechanisms from, for example, open to all events, focus groups, consultations, citizen juries, allows for a broader range of people to interact. And this also means, with regards, for example, to the meeting location, that those organizing those participatory processes should consider going to rural communities and not requesting them to take time off to come to the capital, for example, to participate. And lastly, on the next slide, please, it's the topic of capacities, the capacity building component for social participation. And again, here it's about recalibrating the balance of power, which is rooted not only, but largely in expertise, knowledge, and speaking skills. And we know that the quality of exchanges is largely determined by the competencies of the participants, but it is also largely determined by the capacities of government actors to enable that level playing field where participants are on an equal footing as far as possible, which then allows for more frank and fruitful discussion. For example, bearing the potential to bring up to the forefront the often hidden determinants of health inequities, why certain health services are not accessed or accepted, etc., which then can lead to real policy influence. And there are certain key capacities for social participation, which we group into 3 broad categories that you can see on your screen, and that's recognition. Here it's really about understanding the added value of participation, communication skills, and the technical skills to conduct those participatory processes. All in all, it's important to invest in these capacity building efforts, both to empower rural community representatives and to build the specific skill sets needed by civil servants to create those meaningful participatory spaces. Because if these are actually well designed, a participatory space can really have the transformative potential to challenge those societal conventions. For example, whose voices should be heard, who should have agency over their own health, and who should be empowered to meaningfully contribute to national health policy with a strong component on rural challenges. So one of the key elements of rural proofing should really be to enable those policy dialogues, ultimately to better understand and comprehend challenges faced by rural communities and to broker policy solutions that respond more effectively to rural population needs, in particular to the needs of the poorest and the most vulnerable. So with that, thank you so much. And I'm happy to put the link to the handbook in the chat box for everybody who is interested to glance through. Thank you so much. Over to you.
Yes, thank you so much. Excellent. And could you please also maybe share the link to the NHPSP handbook and the population consultation chapter, as I think they synergize very well. We really appreciate you raising issues of power dynamics and the issues also, I think particularly what touched me is the core component of capacity building with regards to participation, capacity building of both governments and then also of participants and then together looking at really at the barriers, the formal and informal barriers to participation. So thank you for raising those very important issues. Now, I'm going to move on to our last closing address, and this is by Bruce Chatter. So Bruce is he's the chair of the World WONCA. So WONCA stands for World Organization of General Practitioners. They have a working party on world practice. He's also main associate professor and head of the discipline of rural and remote medicine at University of Queensland. He was the founding convener of the Rural Doctors Association of Queensland and Australia, and the founding chair of the Australian National Rural Health Alliance and inaugural chair of the statewide Rural Remote Clinical Network Queensland Health. Bruce remains grounded in the needs of rural communities as he performs these roles while providing comprehensive rural generalist hospital practice and general practice in Theodora. And he's been awarded a Medal of the Order of Australia for his service to rural medicine and to his community. So over to you, please, Bruce, to present. Thank you.
Thanks, Theodora, and it's a great pleasure, and it's been wonderful to hear the perspectives that we've had, and there's been a lot of synergy in those. I wanted to just talk about from someone who lives in a rural area and is involved as a rural health professional, just some of the issues from, if you like, rural looking into the city, and particularly the, if you like, the on-ground experience. First of all, I'd like to gone too fast. I'd like to thank Theodora for bringing this together. I think it's been a wonderful collaboration. It's great to be involved with WHO and also obviously the Food and Agriculture Organisation, the Investing in Rural People with the International Fund for Agricultural Development, the OECD, and also the people who've been around the world bringing together this concept of rural proofing. I love the one about leaving no one behind. I think that's just so important to have that equity in rural areas. Thanks particularly to our speakers from South Africa and the UK and Chile, also, as I said, for their examples. So I think we've talked a lot about policy assurance, and I've got the rural proofing kit here that Brian so well talked about. There's some other guidelines in the health area. I would point out the WHO guidelines on health workforce development. I thought there's a really important point about not only do rural areas have extreme poverty, but the other thing that exacerbates that is the lack of health facilities, the weaker health systems in many of those. And the WHO guidelines certainly aim to approach that. When we come down another level, however, there's a matter of having the local capability. And I particularly liked Nadja's discussion around the key components of that. And there is a need to strengthen rural communities. And as I think both Anna and Kira also looked at is the bottom-up approach, making sure that we've actually got equity and a voice for rural areas. At a very practical level, the Wonka Working Party's been seeking over many years to look at having practical solutions to workforce, in particular in rural areas. And we've had our training for rural general practice and rural health policies, recently a checklist on rural pathways. So we've tried to bring those practical solutions together. And recently at our 17th World Rural Health Conference, we brought those together into a blueprint for rural health. The link is there, but I'm sure after this webinar tonight, we'll be able to send you these resources, so those of you who want to look at them further can. I want to just quickly distill some of the key sort of practical elements about having a good, healthy health service in rural areas. And there's been a few recent changes, if you like, developments in the way things happen in rural areas that have had quite beneficial effects. I don't want to dwell intensely on any of these, but I think a number of speakers tonight have brought out the need for end-to-end planning and integrity in that planning. We need a system that sticks together from one end to the other, not bits that are broken off. We need a consistent, congruent sort of pipeline. There's another interesting concept called clinical courage, which is, I think, something that is a characteristic of rural health professionals. We don't have specialists in rural areas, and you'll see down further a bit about rural generalism, but you have a group of people who have to step up. And the elements of clinical courage are things like stepping up to serve everybody and anybody in a community, accepting uncertainty, deliberately understanding and marshalling local resources, knowing your own limits, jumping the cognitive hurdle of being able to do things in a rural area, and collegiate support to stand up again when people have been pushed by those challenges. The only way you develop clinical courage is having education in context, and you'll see some of the other next things are about rural education in rural for rural. It's making sure that people understand that context. Immersive community engaged education, which was very nicely described by the Strassers in a World Bank document recently. So the only way you're going to get people to understand rural health is to live and work in it. More rural exposure, so making sure that the flipped classroom, if you like, where you've got students and young health professionals out in rural, learning in rural, but using technology to enhance that learning, growing your own, getting people from rural areas, making sure that there's redundancy, that we've got enough backup with power and internet and even basic things like sanitation. There's the idea of step ladder education, where you can keep health professionals in rural areas while they develop extra skills and actually go up through various competencies. Making sure that we engage rural doctors in rural Waka. We've got rural seeds who are very important in developing the enthusiasm of the next generation, and rural students clubs and those sort of things are very important. It's about getting the right health workers in the right spot. We're a group of family doctors, but we've got nurses now involved. We're trying to get community health workers more involved. All of those are important. They all should be working to maximum scope. And that's the next point about rural generalism, that people need to have a broad range of skills supported by technology and specialists. Rural origin, kids coming from rural areas are more likely to go back to rural areas, but we shouldn't put all the burden on them, and we should be able to usefully and helpfully ruralize students. But that goes back to my point a moment ago about lots of exposure. We've talked about the policy frameworks that support all this, and that's been very amply described by a number, but particularly Brian talking about making sure those policy settings are right. And localizing economic benefit. We had one of our doctors at our conference in Albuquerque talking about the massive benefit of having aged care in his town, and the economic benefits of having extra health workers, extra aged care workers, and those people still in their community. So making the most of that rather than seeing it as a burden. It's a bit about attitude sometimes. Living in a rural area, sometimes we do feel, and I think it was beautifully brought out by Kira in particular, about the social participation. There's a lovely little article called about geographic narcissism, and I don't want to push that too far, but sometimes there is a feeling that the city knows best. And in fact, for rural health, rural knows best, and we need to make sure that it's actually facilitated by the city, but with great ideas coming from rural. In Indigenous health in Australia, it's phrased as nothing about us without us. And I was very pleased to see the Journal of Rural and Remote Health recently made a decision in their editorial that as far as it can be determined, an article without people in that country or region, about people in any country or region without authors from that country or region will no longer be published in that journal. So what we're talking about is saying that getting those ideas from rural areas to solve problems in rural areas is particularly important. There is a local effect that we have to think about. So all those policy settings are wonderful, but this is a great study about a discrete choice experiment in Ethiopia with midwives in Ethiopia. And it's what I'd call a policy dose response curve. It's how much response you get for the extra wage bonus. And you can see the black line is the basic wage bonus. But if you actually do things locally to help those people, give them some time, give them some supervision, give them some housing, give them better housing, give them some equipment, you can see that that gets much more bang for the buck. So there's a whole lot of local things that are particularly important in this policy setting that really are needed if they're going to get a good effect from the overall policy. Just want to also mention that I think if we're going to bring all this together, it has to be joined up. So we need to have all the elements working together to provide a good outcome. And so we need to, I said to one of our policymakers in Australia recently, you need to hire a good plumber because you keep taking pieces of pipe out of this part of a pipeline or pathway and putting it into another one, expecting that it's still going to flow. And all you're doing is creating a gap in this area that won't allow the continual flow of workers, for instance, into rural areas. So we need some continuity of policy and a joined up policy. So over the next few months through to February next year in Rural Wonka will, in our conference, be looking at the African aspects and trying to feed into these. But we're so pleased that the WHO have put together this webinar series on rural health equity. The coming webinars are there, and you'll see the key themes around Indigenous populations in the next one, and that's I'll show you a slide in a moment about that being in August. Then there's some with the WHO Human Resources for Health area about developing, attracting, retaining, recruiting and retaining health workers, and particularly gender equality for rural women. About innovations, particularly in low and middle income countries, intersectorial action with the agricultural sector. And I was very pleased to see Erdgen talk about the work of FAO that way, because the agricultural sector really, it's a great collaboration with health information systems for health equity, and then an emphasis on rural women and addressing inequalities in health service coverage. So the next one of these webinars is on the 9th of August, and it's about social participation, inclusion, community engagement approaches for the health of Indigenous populations in rural remote areas. So we'd love to have you there. I think the Indigenous segment will be not only in those developed countries where Indigenous people are obviously disadvantaged, but also in the lower and middle income countries where often some of those people are marginalised. So thank you for joining us tonight. It's been, well, it's tonight my time, it's many other times around the world. I'll just hand back to Theodora just for a final closing remark. Thanks, Theodora.
Thank you so much, Bruce. And we really are very pleased to be able to collaborate with you and all the Wonka Network on this. this webinar series, and thanks for the great insights also with regard to the rural workforce and rural proofing. So I would like to now close the webinar with just a few thank yous. First, thank you so much to the speakers for their excellent contributions and participants for your interest. I'd like to call out Susana Gomez, our consultant in GER working on ethnicity and health equity more broadly, for the great organization to ensure the smooth execution of the webinar. I'd like to also thank Claudia Kiwiros and Pippa Hogton, Wonka, and also other colleagues here who helped to promote the event. And then finally, thanks to Minwi Kang and Nono Similela for their support in particular, for our work focusing on the extreme poor, including those in rural areas, as part of the commitment to leave no one behind in WHO's 13 general program of work. So really permitting us to focus more on rural health as we advance. So thank you, everyone. And we do look forward to seeing you on the 9th of August for the next webinar. And also just to say that under the World Health Day webinar series, there is also a webinar tomorrow. I encourage you to look at the World Health Day campaign on the WHO website, and you can link there to it. It's looking at employment and COVID-19. Okay, thank you very much. We look forward to seeing you again soon.
Thank you, Theodora.
Thank you. Bye-bye.
Thanks, Theodora.